Okay, continuing on here. Etiology. We actually had some discussion about that way long ago. We looked at stroke versus tumor versus head injury. And certainly there are differences. Head injury tended to have perhaps the best outcome. The tumor obviously would have the worst outcome. In general, stroke is in the middle, and within that, lots of variables. But stroke tends to be better than some of the others. Extent of lesion makes a big difference, and that, I think that's kind of logical. The bigger the lesion, the more brain tissue that has been damaged, and the less likely we're going to have recovery. And so I think that's a kind of a self-evident issue. Site of lesion tends to make a difference also. What do we know? Well, we tend to have data that tells us that anterior lesions do better than posterior lesions. Why is that? Well, let's look at the next one then, and that is type of aphasia. Well, we have the same type of answer there, in that non-fluent aphasics tend to do better than fluent aphasics. Well, what's all that about? Why is that? Well, then let's look at the last one that's here, and that is initial severity. What do we base that on? Well, again, if we're going to put this all together, what we're going to wind up with is the following, and that patients who have better auditory comprehension, who are deemed to be less severe, tend to do better overall. Okay. Patients who have better auditory comprehension. Why is that? Because auditory comprehension is kind of a window into the language system. And if a person really understands well, then their language system is really fairly okay. But they're not talking. Well, that may be an external issue. And that may be some kind of an issue in retrieving the words when they want to say them. And it might even be a motoric issue, an apraxia, dysarthria type of thing. Some kind of a processing problem. But in fact, if they have any modality that is fairly intact, and if any is going to be relatively intact, nothing is intact, it's going to be auditory, then that's telling us that the patient is not so inherently very, very severe, and therefore site of lesion would be anterior because that's the person who has better auditory comprehension. Type of aphasia would be non-fluent, and overall severity is going to be better. Okay. Along with that, we probably have time post-onset. And so if we want to come up with some kind of a summary, the patients who will do best are those where we're making this decision relatively close to the time of onset, who are milder, who have better auditory comprehension. Okay. Those are probably the important variables. Okay, this is actually the last topic we're going to be discussing. Perhaps we should have done this 14 weeks ago, and that is, what evidence do we have that aphasia therapy actually works? How do we know that? What is it based on? If you go back to the discussions we did have like 13 and 14 weeks ago, how we got into this, we kind of dragged into this, and because no one else knew what to do with the World War II vets. And so we started to do therapy. And we did that. And we did it for a few decades until the 1970s or so, when all of a sudden, things like health insurance were being asked to pay for aphasia therapy. And the actuaries, who, again, we didn't like at the very beginning, asked the question and say, okay, so we're happy to pay for your therapy. We just need to see your efficacy data. How do you know it works? Well, how would we know anything works? Well, what you have to do is you have to get two identical groups. One of them gets your experimental treatment, the other one doesn't. And you see who does better. Or one of them gets treatment A, one gets treatment B, and you see who does better. Well, if that had been done before we started to do aphasia therapy, then that may have been okay. But now you're asking, or the actuaries are asking that question, 20 and 30 years, 40 years even, after therapy has been started. So even if we don't have good data to indicate that it works, on the other hand, we're totally ethically constrained from saying, okay, let's get 100 patients who are pretty similar and 50 of them won't get therapy. Well, nobody's going to let you do that. How can you not do therapy? You can't do that just for research purposes. And so it became a big problem. And there were a lot of people who are now doubting, now in the 1970s, were doubting whether or not aphasia therapy really worked, because it certainly didn't always work. And it never worked fully. Nobody was ever non-aphasic, and there was never a group of aphasics where some of them didn't get better. And so it kind of puts the whole thing into question. And so people started to try to take advantage of situations and try to do studies without having to a priori decide so-and-so is not going to get therapy. The first study published that had such a design was by a gentleman by the name of Chris Hagen, who got a job in a rehab center in California. And there were a lot of people there who were aphasic. And again, this is really kind of the early stages of our field. And he was asked, he said, okay, so you're the only and the first speech therapist we have here. We have a lot of people with aphasia. We know that. We don't know exactly what kind of aphasia or anything. That'll be up to you to decide. But we want you to do therapy for all of them. Okay, so what would you do in that situation? The first thing you do is evaluate everybody. And so he did. He evaluated everybody there. When he came up with, there's a whole lot more people than he could possibly do therapy with in the time that was allotted. It just wasn't happening. Couldn't happen. He just, the week is only so long, and he couldn't do that. So he said, you know what? I have a problem, but on the other hand, I have a solution, because I'm going to make an efficacy study out of this. Without me having to say, you're not going to get therapy and you are, the reality is not everybody could get therapy. And so what he did is this. He selected 24 patients who were very similar to each other. 12 of them were going to get very traditional one-on-one intensive therapy to the best of his ability. And the other 12 were not going to be ignored. They just weren't going to get that. What they were going to get is kind of group, educational, interactive, recreational kind of work. Stimulation, but certainly not focused therapy. Okay. And what he did is he did that. And he did it for quite a number of months. And then he reevaluated everybody. And what he found is that the patients who had focused individual therapy certainly did better than those who didn't. But it's not like the patients who didn't have it didn't improve also. They didn't improve as much, and they didn't improve in such focused areas, but they did improve in communication. So we had a result that certainly showed efficacy of aphasia therapy, but it wasn't like, but they didn't get better at all. People do get better at all as long as there's stimulation, but they won't get as much better, and they won't get better as quickly, and not in focused areas. So it was a significant contribution to the world of efficacy. The weakness is that he only did look at 12 patients in each group, and they were all very similar to each other. So we really didn't have an answer about lots of aphasics and an answer about all kinds of aphasia. They were all kind of moderate patients, mixed aphasias. Okay, but it was something. In 1979 and on, because this is a study that just kept on expanding on itself, and when I describe its the design, you'll see what I mean. There was a neurologist by the name of Anna Basso, who is in Milan, Italy, and her colleagues were the other two names that you have there, Capitani and Vignolo. We actually had Vignolo before in the token test. This is the same person. And Anna Basso was, again, the head of neurology in Milan. We have to understand what the healthcare system was like in Milan at the time. It's socialized medicine. And there were centers that specialized. And so there was a specialty center for stroke care and rehabilitation that was in Milan. And so if anybody lived within 100, 150 miles or so of Milan, they would come to that particular hospital in Milan for care and rehabilitation of their stroke. And most people who did have strokes did wind up coming there. And they had their medical care there and perhaps their initial rehabilitative evaluations by speech and PT and OT and such. And then when the time was appropriate, if they needed it, they were invited to come back on an outpatient basis for therapy. But what Basso noted is that many of them didn't do that. They didn't come back for therapy. Maybe they lived too far away. Maybe they didn't have the funding to be able to come back. Maybe they just didn't think it was important enough, or they didn't think it was going to be effective. Maybe they just had other agenda items that they were going to deal with. But the reality was they weren't coming back. Many did, many didn't. And so she was sorry about that, but she said, you know what, on the other hand, I've got a control group. I've got a study here. What we're going to do is we're going to take 100 people who all had strokes and all were aphasic, and we're going to take those that came back for therapy and compare them to those who didn't come back for therapy, and let's see how they did. Now, the people who didn't come back for therapy did come back to Milan every few months for medical checkups. That they did. And while they were there, Basso said, listen, while you're here already, give us another hour and just talk to the speech therapist. And the speech therapist would do an evaluation, and just to see how they're doing in terms of communication skills. And Basso did this until she had large numbers of patients, and patients were very varied, and patients were totally self-selected. In other words, she didn't decide who was going to get therapy or not, so she had no moral, ethical issues. She said, listen, everybody's invited to have it. Some people didn't, and some people did. And then she compared the groups. And what she found overwhelmingly is that those who had therapy did better than those who didn't have therapy, and that those who began therapy earlier did better than those patients who began therapy later. Those are two very important observations, and it was solid. It was based on lots and lots of patients. The only criticism that's been leveled at this study is that the patients are not randomly selected. They're self-selected. It could be that those patients selected themselves not to have therapy because they didn't have hope. They were so severe, they thought that nothing was going to get better. They didn't have resources, and then they didn't have motivation, and we didn't talk about that actually in prognosis. Does motivation make a difference? And it does, but it doesn't exist all by itself. It's usually part of a whole lot of other things. And so Basso has been criticized for that, but the fact is her numbers are so large. And when I say and on, 79 and on, she reported this a few more times, the next 100, the next 100, the next 100 type of stuff. And the results are always the same. Those people who get therapy do better than those who don't. People who get therapy earlier do better than those who wait till later. And so waiting till later doesn't make sense, and getting therapy certainly does make sense. That's been a very, very important study. What perhaps makes it most important is that Basso is not a speech pathologist. She's a neurologist. And so the medical world accepted her study much more readily. The last study I want to review is something that's referred to as a VA cooperative study. The VA cooperative study was a study that was initiated by quite a number of speech pathologists around the country. And what they felt was, you know what? We're going to stop this tape because we're not going to have time to finish. We're going to stop it. We'll do one more tape and we'll talk about the VA co-op study and we'll be done.